Welcome to the Indian Council of Medical Research Online Prescribing Skills Course 2020 for the Indian Medical Graduate. I am Dr. Urwashi Parmar, Assistant Professor from the Department of Pharmacology and Therapeutics from SGS Medical College and KEM Hospital, and today I am going to talk about prescribing for women. After viewing this video, please answer 5 multiple choice questions on this video and give a feedback. You will find these in the assignment section. This module has been made by me in association with Dr. Anushri Patil, Scientist E, NIRRH, and Dr. Padmana Sawant, Professor, Department of Obstetrics and Gynecology from SGS Medical College and KEM Hospital, and this module has been reviewed by Dr. Nilima Shirsagar, National Chair from ICMR, and Dr. C.D. Tripathi, Director and Professor and Head, Department of Pharmacology, VMMC and Safdarjung Hospital. According to the MCI Competency Document 2018, there are 21 disease conditions in obstetrics and gynecology with a total 75 competencies related to prescribing in women. Out of these 21 conditions, 6 of the common and relevant disease conditions have been prioritized, and their case scenarios and relevant prescribing information will be presented. The prioritized list is as follows: general principles of treatment during pregnancy and breastfeeding, contraception and anemia in pregnancy will be presented in part 1, and urinary tract infection, vaginal discharge and dysmenorrhea will be covered in the second part of this module. Hence, after completing the module, the Indian medical graduate shall be able to list the points that should be considered while prescribing medicines to a woman, state the principles of prescribing in pregnant or breastfeeding women given suitable examples, state the importance of restrictions on drug use in pregnancy, give examples of commonly used medicines whose use should be restricted or avoided in a breastfeeding woman, counsel a pregnant or a lactating woman before taking any new medication or for continuation of medication, state the points to be remembered while prescribing oral contraceptives, and prescribe rationally for common conditions encountered in a pregnant woman, example anemia. Let us now look at the general principles of prescribing in pregnancy. These are as follows: wherever possible, use non-drug therapy, prescribe drugs only when needed, choose drug having the best safety record over time, use the lowest effective dose, use drugs for the shortest period necessary. Whenever possible, administer drugs intermittently. Avoid newer drugs unless the safety is clearly established. Do not assume safety of over-the-counter drugs, and avoid medication in the initial 10 weeks of gestation. Please refer to the reference material for the list of drugs that have to be avoided during pregnancy. We shall now look at the general principles of prescribing in the lactating woman. While prescribing in a lactating woman, you need to remember the following principles. Estrogens in the oral contraceptive pills and bromocriptine can decrease milk production. The infant may suffer from toxic effects due to the drug secretion in the breast milk. Majority of the drugs, except those acting on the CNS and few others, achieve low concentrations in the breast milk, and the breastfeeding infant is unlikely to suffer from adverse drug effects. Hence, as far as possible, do not alter maternal medication or stop breastfeeding. The patient should be instructed not to take any drug without consulting the doctor, and if in doubt, refer to the manufacturer's recommendation or package insert. The reference material lists the drugs that should be avoided during lactation. Let us now look at a case scenario on contraception. A 30-year-old married lady, Suvarna, wants to space her pregnancy after her first child. She needs a consultation for taking oral contraceptive pills. As an Indian medical graduate, before advising her whether she should take OCs or not, as well as for selecting the most suitable contraceptive preparation for her, what questions will you ask her, what physical examination should you perform, and what investigations will you advise? First, elicit a complete history that includes a full medical history including menstrual history and past pregnancy details, especially in case of married women with children, history of thromboembolic episode, jaundice or toxemia of pregnancy, and history of smoking, diabetes, hypertension, migraine, tuberculosis, epilepsy and gallbladder disease. And finally, history of any medication that she is taking for these conditions to foresee any potential drug interactions, which we will discuss a little later. In ideal circumstances, following history taking, conduct a general physical examination including palpation of breast for any lump and a per vaginal examination for fibroid or other tumor. Record blood pressure to rule out hypertension. Only after all the findings are favorable that an oral contraceptive to be selected and prescribed. For prescribing the most suitable oral contraceptive preparation for a 30-year-old lady in our case, let us first know that oral contraceptives are of two types, hormonal and non-hormonal. Hormonal oral contraceptives are available as combined oral contraceptive pills containing an estrogen, usually ethinyl estradiol and a progestin, and mini pill or progestin only oral contraceptive. The second one is centochromine or meloxifene is the only non-hormonal contraceptive available. Combined oral contraceptive pills are commonly preferred and contain low doses of synthetic progestin and an estrogen, that is ethinyl estradiol, which is combined with either norethistedone, norgestrel, levonorgestrel or desogestrel. They offer protection against endometrial and ovarian cancer and also against iron deficiency anemia. In the public sector, it is available free as Mala N, which contains levonorgestrel 0.15 mg plus ethinyl estradiol 30 microgram supplied through government health centers. Each strip of Mala N contains 21 hormonal tablets and 7 non-hormonal iron tablets. One pill is to be taken every day for 28 days. It is important for an Indian medical graduate to remember that OC pills should not be prescribed in breastfeeding women. How will you advise the woman to take the oral contraceptive pills that you have prescribed? The woman should be advised to take one pill for 21 days every day at a fixed time from the 5th day of the menstruation. Advise her to take it with food even if she does not have intercourse until the packet is over. In a 28-day pill pack, when she finishes the pack, please advise her to start with the first vial pill from the next pack. Inform her that she will be getting withdrawal bleeding when she is on the colored iron tablets. If she vomits 2 hours after taking a pill, instruct her to take another pill from the pack as soon as possible and continue the rest of the pills as scheduled. Tell her to visit the clinic again before starting the next cycle of pills. In case of irregular or unexpected bleeding, reassure the woman, evaluate other causes of bleeding, check the possibility of drug interactions, advise to take the pill at the same time every day, change to a different COC formulation if needed. Further evaluation is needed if the bleeding continues. If there is no monthly bleeding, then evaluate for pregnancy. For ordinary non-migrainous headaches, advise paracetamol 500 mg, ibuprofen 400 mg or other pain relievers. Remember, any headaches that gets worse or occurs more often during COC use should be evaluative. If there is nausea or dizziness, advise her to take the COCs at bedtime or with food. For breast tenderness, recommend a supportive bra, try hot or cold compresses. Paracetamol 500 mg or other pain relievers can be prescribed. For weight gain, review her diet and counsel her that current OC preparations do not necessarily increase weight. For changes in mood or changes in sex drive, give her support as appropriate. Acne usually improves with COC use. If they persist, prescribe a different OC preparation. If one or more pills are missed from days 1 to 21, advise the woman to take the pill as soon as she remembers, take the pill at the usual time next time, and keep taking the pills as usual, one each day. As mentioned earlier, drug interactions can occur with oral contraceptives. For example, oral contraceptives decrease the efficacy of anticoagulants, levothyroxine, oral hypoglycemic agents. Oral contraceptive pills increase toxicity of theophylline, imipramine, cyclosporin and glucocorticoids. Antiepileptics, rifampicin, griseofulvin, ampicillin and tetracyclines decrease efficacy of oral contraceptive pills, and ascorbic acid 1 gram daily increases efficacy of oral contraceptive pills. Additional information on contraceptive pills is given in the reference material. Thus, a prescription for Suvarna who wished to space a pregnancy should be given the following prescription: tablet ethinyl estradiol 0.03 mg plus levonorgestrel 0.15 mg 1 per day into 21 days. Visit the clinic again if the pill is forgotten to be taken more than once. Let us now discuss another case scenario commonly seen in India, namely anemia in pregnancy. A 26-year-old multiparous woman, Anita, presents to the ANC clinic in the 14th week of her pregnancy. She has complaints of fatigue since the past 3 to 4 months and has recently developed a taste for eating ice. Her previous delivery was normal and she does not have any history of accident or operations. On clinical examination, her conjunctiva is pale, there is mild spooning of nails, and her laboratory investigations reveal that her hemoglobin is 10.5 gram per deciliter and stools are negative for occult blood. What additional history do you need to elicit? You need to elicit a proper history to find out the causes of anemia. Important points that you should elicit are whether she has been vomiting due to morning sickness, what kind of diet does she have, and is she the last person to have food in her house, whether she has heavy menstruation before pregnancy, whether she had frequent pregnancies with less interval in between the 2 pregnancies, has she taken any treatment for worm infestation, history of any drug intake, example warfarin needs to be asked as warfarin increases bleeding tendency and is teratogenic too. Rarely, the patient may be suffering from bleeding disorders which needs to be asked and treated accordingly. You need to physically examine the patient for varying degrees of pallor, edema of legs, soft systolic murmur in the mitral area due to physiological mitral incompetence, and crepitations at the base of the lungs due to congestion. The investigations that you need to advise are hemoglobin estimation, MCH and MCV, and stool examination for worm infestations need to be done. For an effective therapy of anemia in pregnant women, you need to know the hemoglobin levels of mild, moderate and severe anemia. For mild anemia, the hemoglobin range is 10 to 10.9 gram per deciliter. For moderate anemia, the range is 7 to 9.9 gram per deciliter, and for severe anemia, the range is less than 7 gram per deciliter. Infections due to soil transmitted helminths are common in India. Such infections are one of the major reasons for malnutrition and anemia, which are the reasons for concern especially in pregnant women. Hence, deworming in pregnant women should be done with one dose of 400 mg albendazole, one tablet, preferably given during the second trimester. Please note that the treatment plan for moderate to severe anemia is given in the reference material, as the patient in our case has a hemoglobin of 10.5 gram per deciliter. Treatment plan for mild anemia is given. As an Indian medical graduate, the treatment to be prescribed by you at the first level of treatment at all levels of care are 2 tablets of iron and folic acid containing 60 mg of elemental iron and 500 microgram of folic acid daily. Consider parenteral iron therapy for IV iron sucrose or ferric carboxymaltose for patients coming late in pregnancy or with low compliance to oral therapy. You should ask the patient to follow up after 2 months. You can think of discontinuing the treatment and subsequently putting the patient on prophylactic iron or folic acid dose if the hemoglobin is normal. If you find no improvement after first level of treatment, that is, if the increase in hemoglobin is less than 1 gram per deciliter after 1 month of treatment, please refer the patient to the first referral unit or district hospital to investigate for the cause of anemia, where it may be managed with IV iron sucrose or ferric carboxymaltose. Most of the women in India do not get folic acid normally in their diet. Hence, a prophylactic iron and folic acid supplementation is necessary in women of reproductive age and pregnant women irrespective of anemia. You need to prescribe 400 microgram of folic acid tablets to all women in the reproductive age group in the preconception period and up to the first trimester of pregnancy daily to reduce the incidence of neural tube defects in the fetus. In pregnant women and lactating mothers with children of 0 to 6 months age group, you need to prescribe a tablet of iron and folic acid containing 60 mg elemental iron and 500 microgram of folic acid from the second trimester and continue prescribing for 180 days postpartum. You need to know the most common oral preparations which are available. They are tablet ferrous sulfate, recommended as per Anemia Mukta Bharat 2018 guideline, tablet ferrous gluconate, tablet ferrous fumarate, mixture of iron and ammonium citrate and tablet ferrous ascorbate. While prescribing oral iron therapy, you need to inform the patient the following side effects, which are epigastric pain, heartburn, nausea, vomiting, staining of teeth, metallic taste, colicky pain, diarrhea and constipation. While prescribing oral iron therapy, you need to advise the patient that taking iron preparation with food may cause poor absorption. Hence, it has to be taken after lunch. Also, the patient should be advised to avoid taking iron and calcium supplements together, as calcium decreases the absorption of iron. You need to keep in mind that for improved oral iron tolerance, initiate therapy at low dose and gradually escalate to the optimum dose. Supplementary iron therapy is needed for all pregnant mothers from 14 weeks onwards. For hemoglobin level of 11 gram%, you need to prescribe 1 tablet of ferrous sulfate containing 60 mg of elemental iron. You need to keep in mind that the dose should be proportionately be increased with lower hemoglobin levels to 2 to 3 tablets per day. If you need to prescribe and administer parenteral iron therapy, the most common preparations available in India are ferric carboxymaltose and iron sucrose. Appropriate indications for parenteral iron therapy are non-compliance to oral therapy, inability to tolerate oral iron, cases seen for the first time during the last 8 to 10 weeks of pregnancy with severe anemia, and chronic bleeding with depleted iron stores. Before administering any of the above parenteral preparations, keep in mind that you need to calculate the dose of parenteral iron using the following formula: 0.3 into W into bracket 100 minus hemoglobin into 100 divided by the age factor, where W is the patient's weight in pound, hemoglobin is equal to observed hemoglobin concentration in percentage, additional 50% is to be added for partial replenishment of body iron store. Ferrous sucrose is a commonly used drug for IV infusion. It has an advantage of being safe with less side effects. The infusion rate for ferrous sucrose, which contains 20 mg elemental iron per ml, is 100 mg per dose. Hence, you need to prescribe and administer one dose daily for 10 days. Another parenteral preparation for intravenous use is ferric carboxymaltose, which consists of ferric hydroxide core stabilized by a carbohydrate shell, which allows for controlled delivery of iron to the target tissues. Administered intravenously, it delivers a replenishment dose of up to 1000 mg of iron during minimum administration time of less than or equal to 15 minutes. Hence, after prescribing ferric carboxymaltose, it may be administered either undiluted by slow intravenous push at the rate of 100 mg per minute or can be administered via infusion. Each ml contains 50 mg of elemental iron. Information on the intramuscular iron therapy and diet rich in iron and vitamin C is given in the reference material. Hence, the drugs to be prescribed for the 26-year-old multiparas patient Anita are tablet ferrous sulfate 100 mg 1 tab twice a day for 3 months, tablet albendazole 400 mg single dose in the second trimester, dietary advices and follow up to check hemoglobin after 1 month. So, let us now summarize that what we have learnt in the past few minutes. Drugs used in pregnancy and lactation should have a proven efficacy and prescribed only when necessary. Clear instructions on how to take the contraceptive pills and adverse effects of the therapy should be communicated to the patient. Therapeutic and prophylactic iron and folic acid supplementation is necessary. We have now come to the end of the session on prescribing in women. We will discuss the remaining 3 conditions in the second part of this module. These are my references. I would like to thank the RUMC committee of St. G.S. Medical College and KEM Hospital, Mumbai. Thank you for watching this video. Hope you are now ready for attempting the MCQs. Please access the MCQs in the assignment section and submit the answers. Please also complete the prescription evaluation as per the tutorial, which I hope you have already seen. Thank you and happy learning.